Gentlemen, Mr. Chairman, thanks for the invitation. First, some anatomical consideration regarding the location of the reflux in PCV. We can have reflux from the ovarian vein, which is the main trunk, but there is also some thin collateral vessels toward the periuterine veins and toward the left to the right side. We have reflux from the internal iliac vein branches toward the vulvar and perineal varicosis vein too, as you can see here. And this reflux arises from different internal iliac branches, such as uterine vein and pudendal vein, where you can find varices, a lot of varices too, and escape points, most often for obturator vein, gluteal vein. So, two different types of vessels. To my point of view, the goal of treatment are twice. First, we have to stop the reflux, and we want to obtain a ligature-like effect, and we need to obtain a mechanical occlusion along the ovarian vein with the coils, plugs, liquid agents such as glue, EVOH, copolymers, and to obtain a distal occlusion of the internal veins to avoid recurrences via collateral veins and anastomosis. And this occlusion should be distally placed because we don't want to increase the pressure in the entire pelvic venous system. Second goal is to obtain a retraction of the varicose network, and it's very, very important. So we need to obtain a good distal filling of the vessel, and it's a reason why we need to use liquid agents to obtain close contact to the vessel wall, to have an inflammatory effect on the vessel wall, and you can have this with glue, sclerosants, and we can use foam with sclerosants to emphasize this effect. And also we want to avoid injury of surrounding nerves and organs. It's a reason why there is no place for a tunnel. These are the properties summarized by Chirarongo. What do we have? In our tool, we have solid embolic agent, coils, vascular plugs, balloons. When using coils, there is a small difference because the occlusion depends also to platelet activation, but usually it's not a problem in PCS. We have some liquid embolic agents, glue, NBCA, Glubran, sclerosing agents, and EVOH-based embolic agent. Pay attention that you only have a true damage of the vascular endothelium when using glue or sclerosing agent. First, coils. Coils in veins, there is some tips and tricks we have to know before embolization. To oversize 30% compared to the vessel diameter is better in vein. Detachable coils are, of course, more safe than non-pushable coils, and macro coils are less prone to migration than micro coils. Pay attention that using the sandwich technique and when injecting sclerosant, you may have spasm and retraction of the vessel, and the size of the ovarian vein may decrease. So you have to inject during embolization to see the size of the vein. Concerning the ovarian vein, you can use the coil overlapping technique with a non-detachable coils. You place distally the first coil, and you pass through the coils to release the second coils until the end of the embolization of the ovarian vein. Concerning the branches of the internal iliac vein, it's very important to place coils as distally as possible to avoid the risk of migration. Because, as previously said, coil migration is an issue and is more common with internal iliac vein embolization, and described in up to 4% of patients, and carries the risk of embolization in the vena cava pulmonary arteries. Liquid agent and first glue. In France and in Europe, we only use Glubran because it has a CE mark, but it's as efficient than NBCA. The patient can be placed in a semi-upright position in order to reduce the risk of migration, or you can use a Valsalva maneuver or to place coils and inject through coils glue. This is an example of the crossover technique recently reported by Lorenzo. With a microcatheter, you go into the left ovarian vein, through the varices into the right ovarian vein, and you inject glue, pulling back the microcatheter in order to have a complete filling of the varices and both ovarian vein. Main complications are, of course, glue migration into the pulmonary circulation. We have some recent reports from French colleagues who use IVOH-based embolic agent, Onyx, which is a biocompatible copolymer dissolved in DMSO, and that when in contact with blood solidifies as a rigid cast, as a kind of plastic, and can be pushed and extended in different directions. There is no effect on the vein wall and no vein retraction with Onyx. Clinical and technical success are very high, up to 90%. The advantages are easy fluoroscopic monitoring and control, and it also can be used with coils. Disadvantage is pain during injection of DMSO, requiring sometimes intensification of anesthesia or general anesthesia, and some specific complications, especially pulmonary toxicity, allergic reaction. The total amount of Onyx you can inject is limited. It has to be respected, and you also need to use a DMSO-compatible microcatheter, which are expensive. Sclerosants are the old liquid agent used in this pathology. They are causing irreversible damage to the venous wall, and it's responsible for vessel retraction. Injection can be done during Valsalva maneuver or using balloon after coil placement, like with glue. And you can adjust the concentration to the size of the vessel you have to treat, with small concentration in very thin vessels and high concentration up to 3% in large vessels. We have no guidelines in PCS concerning the maximum of dose we can use, but regarding what is done to treat a saphenous trunk, we do not exceed a maximum of 20 milliliter of